Welcome to this episode of Morning Report Emergency Medicine. I'm Alec Weir. It is that time. We are getting towards the end of the academic year. I feel like Green Day's Time of My Life or Vitamin C's graduation song should be playing in the background. But let's see what we've learned over the past year. This was our first case. This was a young man who came in, brought in by police after ingesting a large amount of cocaine. And as you can see, he's tachycardic with a wide QRS. That's because cocaine is a class 1 antiarrhythmic. It has sodium channel blockade as well as QT prolongation, treatments with bicarb until the QRS narrows. And that's exactly what happened in this case. He was given multiple amps of bicarb until that EKG narrowed. Next, PJP, pneumocystic jirovecii pneumonia in HIV patients. Classically a butterfly wing appearance on the x-ray. It's a yeast-like fungus. Common AIDS defining opportunistic infection. Actually the most common. It has extrapulmonary features, things we don't always think about, like hepatosplenomegaly, skin lesions, and ocular lesions. But the chest x-ray findings, classically butterfly wing appearance, but the chest x-ray can actually be normal. This is when you want to throw that LDH out there. Look for an elevated LDH as well as a low CD4 count. The keys are just to think about it. In your HIV patients or a patient that you think may be infected with HIV, sometimes this is what they present with. Send off that LDH and CD4 count. Remember, the chest x-ray can be normal. And then steroids. Who gets steroids? Well, steroids are given prior to the treatment with Bactrim. Classically, it's patients with a PaO2 less than 70. Although that's roughly around SpO2 on a pulse oximetry of 92-93%. But there are some that say if you're giving Bactrim, you should be giving steroids to these patients. What do we have here? One of my favorite cases of the year. We have a patient who was found altered outside, middle of the winter. Those are Osborne waves. This is hypothermia. The key is to get the temperature on these patients, and it may be difficult. You may need to do it by a little more invasive means than you're used to. Things like rectal temperatures or bladder Foley monitors or even esophageal temperature probes. These patients have cardiac and respiratory effects that are deadly. And the key is to be aggressive, whether it be external warming with warm blankets or a bear hugger, or internal warming with things like Alceus catheters, which we usually think of for cooling patients, but you can use it to warm patients. Warm IV fluids, warm bladder lavages, and even chest tubes for intrathoracic lavage. This picture actually ended up on SAEM's visual diagnosis. Congrats to the residents involved. This was a patient, hypertensive, coming in with blurred vision, something we see all the time. But as you can see highlighted by the arrows, this patient is having a central retinal vein occlusion. This is blood and thunder because of a hypertensive retinopathy. So that blurred vision in hypertensive patients can be real and it can be subtle. Your fundoscopic exam, you'll see that blood and thunder like you saw in our picture here. And there's a grading system for hypertensive retinopathy. It's a little too complex for in the emergency department, but remember that 1% of hypertensive emergencies, true hypertensive ICU level emergencies, are hypertensive retinopathy. And with the central retinal vein occlusion like we saw here, it's that blood and thunder, usually unilateral, and they have underlying causes like hypertension or diabetes. This was actually one of my cases from the emergency department. This is when I really got hit home, and I know I had heard it a million times, but it never really landed for me on the systematic approach to the EKG. This lady has a history of AFib. She's coming in with palpitations and chest pain. Well, she's in AFib with RVR. But is there anything else? Well, yeah, systematically it looks like she's got some elevations here in 2, definitely 3, definitely AVF, and she has reciprocal depressions, AVL, 1, V2, little bit in V3. This lady's having a STEMI, not just AFib with RVR, but she's having a STEMI. And the key is that systematic approach. Don't lock in on the first piece of pathology you find. It's just like with x-rays. The easiest one to miss is the second fracture. Have a system for your EKG. This patient actually didn't have a thrombus. She had an embolus that went into her coronary vasculature. Gentleman falls, ends up with his hand above his head and an x-ray that looks like this. This is a luxatio erecta. This is an inferior glenohumeral dislocation. It's actually less than 0.5% of all shoulder dislocations. It's not subtle, okay? This is very easy to see. The patient can't put their arm down. Like the kid from Christmas Story, they can't put their arms down.
What is it?
I can't put my arms down!
It's a key, as always, to get a good neurovascular exam and know the reduction techniques. You can either do a traction counter-traction, where most of your force is placed on the humerus to release it from the inferior portion of the glenoid, or you can do the two-hand technique, where you convert the inferior dislocation to an anterior, more common dislocation, and then relocate it like you know how. Make sure, of course, to get complete post-reduction films, and that includes either an axillary or a scapular Y to make sure that you didn't turn that inferior into an anterior dislocation and then miss it. Pre-eclampsia, working our way towards the serious stuff. This is gestational hypertension, which is usually systolics 140/90 plus proteinuria. With seizure, now you're talking eclampsia. The progression is unpredictable. This occurs in 2 to 7% of pregnancies and can happen up to 6 weeks postpartum. This I didn't mention in the first go-round, and it was mentioned in our conversations, that even up to 6 weeks, you have to be thinking eclampsia in a seizing female patient. Remember that preeclampsia is the middle of that spectrum, and then eclampsia is when seizures are present. Proteinuria may vary, so a negative UA in the emergency department does not rule out preeclampsia. And the treatment is magnesium, and it's big-time magnesium. This is 6 milligram IV loading dose magnesium if the patient is seizing. This was a patient who came in with vague complaints over a month's worth of chest pain and shortness of breath. And I want you to take a look at the rhythm strip up on the monitor. I'll play it again. Take a look at the rhythm strip up on the monitor. Look at the variation in the QRS complexes. And actually, you can even see it in the pulse oximetry reading getting down to his finger. And you rightfully know that this is electrical alternans. Here's his echo video, and I apologize, the echoes get much better as the year got on, and we got a little more technologically savvy, but you can see this large pericardial effusion with collapse of the right ventricle. This was tamponade, and you can see it on his EKG or on the monitor as well as on the ultrasound. The physical exam finding, Beck's triad of distant heart sounds and JVD and hypotension. The triad should be ultrasound jelly, a probe, and the patient's chest. The causes of pericardial effusion in this case ended up being a newly diagnosed cancer. Don't forget about your dialysis patients with uremic pericardial effusions, as well as your patients with autoimmune diseases. Another STEMI case. This STEMI is a little different. Our last STEMI was going fast. This STEMI is going good and slow. This patient was bradycardic, hypotensive, diabetic, not actually complaining of any chest pain, just some nausea and generally not feeling well. She's got diffuse ST elevations with depressions in 1 and AVL. She ended up going to the cath lab, but she was in cardiogenic shock. And now this lady's was from a myocardial infarction, but there's lots of causes, like ischemic, but structural causes, like papillary muscle ruptures. There's also non-structural causes, like infection, trauma, toxicologic, genetic, or even cancerous. The treatments, IV fluids. That's the first thing you can give them. You give them a little bit of an IV fluid bolus to see if you can help augment that cardiac output. PCI or fibrinolytics if it's ischemic. Vasoactive agents to help with that forward pump. And then mechanical support like an intra-aortic balloon pump or even ECMO if you have it. And I found a lot of this year, the things that really caught my eye were some of our toxicologic cases. Here we have a patient who's been drinking antifreeze, and her ethylene glycol level was 80. Normal is 0. There should be 0 ethylene glycol inside of your body at any given time. She also had an elevated anion gap, low calcium, and a lactate of 7.6 with a pH of 7.24 to go along with it. And it's not so much that the ethylene glycol is dangerous, but the metabolites are dangerous. That's what causes the acidosis and the kidney injuries. But the treatment is fomepizole, which helps prevent formation of those metabolites. And then dialysis. You can use dialysis to help remove the ethylene glycol, so you stop its metabolism and you remove the parent molecule. And then I can't move on without talking about poor Nastia-Lukin. As she really helps, literally and figuratively, drive home the next case. This is a lady who had a fall, actually walking through the parking lot. Her neurologic exam, she's alert, she moves all extremities, but her right upper extremity and her left upper extremity are pretty weak. She goes to CT scan, which is negative, but these are true neurologic deficits. She has central cord syndrome. The sensory exam and central cord variable. She had a normal sensory exam. Her motor exam fits in perfectly. Upper extremity weakness, distal musculature more significantly than the proximal, and that's exactly what this patient had. It is the most common incomplete cord injury, and it's a hyperextension injury. You have bilateral motor paresis, upper greater than lower, like in our case, and distal greater than proximal. And as you age, your prognosis is worse for recovery of neurologic function. That's it. That's our first run through of the review. That's not the whole year. That's about half the year. Some things got cut. Feel free to go back and watch anything you want to get a little more in-depth discussion on. But as always, you can follow me on Twitter at @weir_Alec and subscribe to that channel for more updates. That's right. Because I'm moving on, I don't know what my year looks like next year. I'm starting an EMS fellowship. 2 of our up-and-coming third-year rock stars from my program have taken over, but they've got a new name, a new logo, and they gave me a little bit of a sneak peek of their first episode, and it is gold. I'll put a link to their site in the description of this video. It's called The Clinical Correlation. Ian Bodford and Liang Liu, they do a phenomenal job. Click on over, subscribe to their channel so you can keep getting these great cases from our residency department.